for joining the Superior Health Quality Alliance Nursing Home Leadership Roundtable, where we continue our series turning your deficiencies into efficiencies. Today is all about F0761, label and store drugs and biologics correctly. My name is Constance Tetrov, and I am a quality improvement advisor with Superior Health Quality Alliance. I am accompanied by several of my colleagues. We usually have Miss Tabitha, Margaret, and Miss Mykesha, who will be assisting with monitoring the chat and providing you with any of the links, such as the PDF of the presentation and the survey at the end, as well as our guest speaker today, Miss Patricia Leonard. We host these 1-hour sessions on the second and the fourth Wednesday of the month. The first half is a didactic presentation, then the remaining time will be for questions and answers. The presentation link has been dropped into the chat, so you can access it there. Please use the chat box to share any comments, questions, and even resources during the presentation. Besides learning from our speaker, we learn from each other and our peers. Towards the end of today's event, we'll also put an evaluation link in the chat, and that will only take you 1 to 2 minutes to complete. We use that information and your feedback on those evaluations to help give you a better experience. Please help me in welcoming our guest, Ms. Patricia Leonard. We look forward to sharing your knowledge. We look forward to you sharing your knowledge with us today. The floor is all yours, Ms. Deere.
All right, well, thank you very much for that warm welcome. As they mentioned, I'm Patty Leonard. I'm a registered nurse, and I've been a nurse for very many years. The last part of my career has been spent as a director of nursing, as well as working as a casual nurse. So are you seeing my screen now? No? Okay. Well, now.
Yes.
Yeah. Okay, great. So we're going to talk about medications and pharmacy services, and we're going to talk about a few more F tags. So the objectives today would be to understand pharmacy services, that they are very complex. We'll talk about several pharmacy-related F tags, and understand that there's many opportunities to receive survey citations, and then we'll talk about some tips to prevent receiving these citations. A little background: pharmacy-related citations are consistently listed in the top 10 for Minnesota, Michigan, and Wisconsin, which are all part of the CMS's Chicago region. And if you think about it, medication administration consumes a large percentage of the nurse's time. If you watch a day shift nurse, she probably just finishes her morning med pass and she's starting into her noon med pass. So think about that in relationship to her entire shift. If she's working an 8-hour shift, she could spend over 6 hours of her time administering medications. And part of that is because residents receive, many of them, over 10 medications. So that just makes this process prone to risk and prone to problems. When I looked through the state operations manual, I came up with over 20 regulations that could be related to medication administration, and we're going to go over 6 of them. The first one is the right to self-administer medications, which is 554. We're going to talk about pharmacy services, 755, drug regimen review, 756. 757 is unnecessary medications. And medication errors is 759 and 760. And then here's labeling and storage, which is 761. Now, the frequency of these is pretty consistent from state to state. The scope and severity does vary. But labeling and storage was almost in a quarter of all facilities. Now, I did take this data from a couple months ago when I started preparing for this presentation, but I doubt that it's changed that much. Pharmacy services in about 19% of facilities, and med errors, which I thought might be higher, was 12%, unnecessary meds 9%, drug regimen review almost 8%, and self-administration of medications was in 7% of facilities. So we have a poll here, and it's, do you worry about compliance with medication and pharmacy-related F tags? Are we able to get that up? Here she goes. So if you could just take a couple seconds to respond to that, Paul, we'd appreciate it. This feedback is helpful for us as we look towards future presentations, engaging the degree of concern that you have. So it looks like a little over 50% are worried about their medication administration. So thank you. So we can end that poll. So we're going to go by order of frequency. So the top tag 761, labeling and storage of drugs and biologicals. This is taken from the State Operations Manual. So the requirements for this tag are that the drugs and biologicals that are used must be labeled in accordance with currently acceptable professional standards. You're going, okay, yeah, right. But you need to make sure that you follow the cautionary instructions and watch the expiration dates. The other part of this regulation talks about how to store and keep safe your controlled substances. And the regulation also wants you to make sure that everything is safe and securely stored. It talks about your refrigeration, those temperatures of your refrigerator where you store your meds. It talks about preventing diversion, limiting access, and again, the controlled substances requirement for a second lock compartment for those medications. So we have another poll, Constance. Does your facility have a process to check and remove expired medications? It would be a yes or no.
I launched it.
Okay, great.
100%, yes.
Super. That is great, because I'll be honest, a lot of facilities don't. So very good. Thank you. So here's some examples when I read through 2567s of citations that were issued for labeling and storage. The medication cart was left unlocked, or it was not under direct observation. So if you get beyond arm's width, they're going to say it's not controlled. You need to make sure that it's locked up. Medication cups left at the bedside with meds in them, and the resident not knowing what's in the cups. Medication left outside the resident's room. In this case, the nurse set them down, went down the hall to get water, and of course, the surveyor walked by and saw the meds sitting there. Or meds left in a med cup. In this case, it was an ointment. Refrigerators, lots of issues with refrigerators. So temps not being recorded, or temps were recorded, they were out of range, and there was no corrective action noted. Some cases, there wasn't even a log or a thermometer present. Loose pills found in the med cart. They may say that you've not given the meds then. Syringe with solution found in the med cart. Pills and med cups in that top drawer. I know the tendency is you go into the room and the resident's not there, that you'll come back and grab them. It's just not a good practice. More examples, wasting meds. The resident's discharged and those meds sit in the med room. They sit in the med carts, as well as wasting those controlled meds that are discontinued. Bags of meds. How many times do your families bring that bag of meds in? You stash it in the med room, or the family brings it in and it's at the resident's bedside. You need to send them home. Surveyors have also found unlabeled insulin syringes in the med carts, lidocaine that's stored with oral medications, with eye drops, just other kinds of things in the med carts that don't need to be there. Enemas on top of tube feedings. Talks here about unopened vials of insulin in the med cart, expired meds in the cart or in the med room. Think about all those stocked meds. You need to have a process. No names or dates on inhalers or eye drops. So taking those things into consideration, think about how you can avoid getting those citations. Generally, all the pharmacies that I've worked with will give you a list of med storage guidelines and the expiration dates. If it's 28 days for the eye drops. And I would recommend that you have a copy of them on each med card so that the nurses can quickly look at them if they are unsure. And obviously, don't leave the med card unsupervised. Nurses can't leave meds at the bedside, not to stash things in the med card. Audit the carts frequently. It was kind of my pet peeve. I always looked at them, and I always looked in the med rooms. to make sure that, your orals were separate from your rectal meds, that your eye drops were separate from your eardrops. They all need to have dividers in your med carts so that they're all separate. Put some extra stickers in the top drawer of the cart so that they can label the insulin pens or vials or eye drops or whatever if the label falls off. And if the label, you can't read it, order a new one. Do MedPass education. Make sure that this is covered in detail on hire. I would recommend annual competencies for this as well. You can use the pathway that CMS puts out. It's a pretty good med observation form. And then talk about how you're going to do the resident treatments. I know there are nurses treatments per se that we ask the CNAs to put on sometimes, but what are you going to do with that med cup with the ointment so that it's just not sitting around? Get a process for removing meds for your discharge meds and then wasting those controlled substances. And then again, your refrigerator, making sure that someone is auditing that the temps are being taken and recorded and that the staff knows what to do when the temps are out of range. So if the temp's too high, you need to turn it down. If it's really high, then everything in that fridge needs to be moved somewhere else so that it doesn't impair the integrity. And here's just a little bit more information on med carts. Schedule for cleaning is recommended. Some people take them out and power wash them. A lot of places will buy a little shop vac so you can, vacuum up all that debris that gets in the bottom. Each nurse should clean it up and disinfect it with disinfectant wipes at the end of the shift. Make sure that the applesauce or pudding, whatever you're using for med administration, is dated. Check your facility policy. I always threw mine out after each med pass, but maybe you're allowed to keep them for the shift. Protect your spoons. Make sure that the handle is up and that's what you're grabbing when you grab them out of the container. And then make sure, as I said, there's no extra things on the cart. There's no food, there's no drink. You don't have a lot of dressing supplies in there. We talked about keeping things separate by route, monitoring expiration dates. And if you have a sharps container on the side of the med cart, making sure that that is discarded before it's overflowing and making sure that your narcotics are all accounted for. Same thing really for your med room, making sure that it's tidy and doesn't get junked up with whatever extra items you want to store there. Keeping track of the temperatures, and if there's a buildup of ice, making sure that your fridge is defrosted. A lot of facilities now are purchasing refrigerators that don't have freezers. That's best for maintaining the integrity of the vaccines. And some of them actually even have automatic temperature recorders as well. Need to have hand washing sink in the med room. We talked about no stashing, limiting access. This room is supposed to be locked. And if you have locked items that need to be refrigerated, they need to be a lockbox in your refrigerator too. And so your second lock would be your med room lock. Addressing your expired meds and getting rid of them. Making sure that if you have to prepare any meds, it's a clean area. And again, having a sharps container available that's not overflowing. So I'm going to go on to 755, which is pharmacy services. And the regulation states that the facility must provide or obtain drugs and biologics for routine, for emergency use, and after hours. So, and I know for some facilities based on your location, this is really a challenge, that emergency med runs and the after hours. So knowing that with your contracted pharmacy, you have to come up with some kind of arrangement if it's, using the local Rite Aid, Walgreens or whatever pharmacies across the road from you to get those meds on off hours. And talking about a lot of facilities and states now have laws that let med techs give meds. So knowing what your state law is and following that. You must provide pharmaceutical services, including procedures for acquiring, receiving, dispensing, and administering medications. You have to have a consulting pharmacy, licensed pharmacist as part of the contract. And this talks about records of receipt and disposition of controlled drugs. And I'll get into that a little bit more in a minute here. So controlled substances, this is where you need to take more time and more vigilance and look at all the details. So you have to log in the receipt of all the controlled substances. So when your pharmacy delivers, if they have a list there that says you should be getting 4 different med cards, you need to look at each card and make sure that all the drugs are there that are supposed to be there. And then you can sign for them. And then when the nurse gives these narcotics, she needs to sign out each dose on the count sheet as well as on the medication administration record. And whenever nurses change cards, pass off to the next nurse, they need to count. So they need to count the number of cards that are in the card, as well as the number of pills on each card. And only at that time will they both sign. So this isn't something that one nurse can do in preparation of getting out of there in good time. And each 2 nurses need to eyeball everything and then they sign, because the nurse that's coming on is assuming responsibility for that card and the medications in them. Make sure that you have a process and procedure in place for witnesses and your wastages, and reconcile and account for all doses. And if you can't account for all doses, then the outgoing nurse needs to stay till they can figure this out, where it is. And there needs to be a policy and procedure in place for who they're calling, if it's calling the DON, the on-call nurse, or whatever. This is very serious. And as leaders in facilities, you need to make sure that you're always alert for signs of diversion. And that in itself could probably take up a couple of presentations. So what kind of citations do we see for F755 pharmacy services? Read a 2567 that talked about their policy had that they need to have a witness for disposal of a fentanyl patch that was removed, and there wasn't a witness. Backup system was not followed for obtaining meds, missed doses of medicine. In this case, the resident didn't receive pain medications as ordered. The previous example, there was 19 doses of a medicine received. It wasn't there, which is why it wasn't given, but at the same time, nobody was investigating. The nurses need to call the pharmacy to find out why. Facility was cited for failure to reorder medications in a timely manner. This another one to do with narcotics not being signed out. Counts weren't accurate. They weren't reconciled, and expired medications were found in the refrigerator. Again, medications left at the bedside. And this one was kind of an interesting case where it had to do with holding a blood pressure medication and communications between a nurse practitioner and the dialysis clinic. And it just was very poorly handled, and a lot of steps were missed to make sure that the medication was given as it properly should. And in this case, the facility was cited because the nurses weren't trained for the use of an infusion pump. And this is where the surveyor chose to place this citation. So how can you prevent them? These problems from happening? Again, policies and procedures, especially for those controlled substances and the wasting, and what to do when the counts aren't right, and making sure that those counts are done consistently. I always looked in the NARC books and would stand around when they were doing these intershift counts to make sure that they were doing them the way they should be. And when I was working the floor, whether or not I was a DON filling in, I just made sure that I followed all the best practices and the policies and procedures so that I could model that good behavior. And procedures for getting backup medications. So if you have a Pyxis machine, making sure that the nurses have, that their codes are working, that they have a process to get meds, to get that emergency number. And what do you do if there's only one nurse on night shift and you need to have another witness? I've heard some workarounds, but you need to come up with whatever will work and is accepted at your facility and your organization. And establish a medication reordering procedure. So if you're down to 5 pills and it's a daily med, is that when you reorder it? Some pharmacies now are able to provide automatic refills. Maybe that's something you want to consider, using your electronic medical record system for all the advantages that it has when it comes to your meds being administered and tracking. So we have another poll here, Constance. Do you feel that your controlled substance reconciliation process could be improved?
We have still coming in. Okay. 8 out of 11 say yes, 77%. No, about 29%. We still have some answers coming in. So about 50% of people voted.
All right, well, thank you, everybody. And hopefully you've got some tips. If you have additional questions, I'd be happy to answer them at the end. And if I don't have the answers, I'll see if I can get them for you. So 759 and 760 have to do with med errors. So med error is defined in the state operations manual, and you get a citation if your error rate is over 5%, and they want your residents to be free of any significant med errors. And they define a med error as if you don't administer the medication as it was ordered, you don't follow the manufacturer's instructions. So that would include missed meds, administered without an order, wrong drug, wrong dose, wrong route, wrong resident. And they again talk about that accepted professional standards and principles and that following your state regulations. And I know when it comes to state regulations, that a lot has to do with the med techs, what they can give and what they can't give. And then the significant med error is one that causes the resident discomfort or jeopardizes his health or her health and safety. Significance may be subjective, and that's where we see variances in state to state and even within the state itself, and depend on the individual situation and duration. Med errors, I've seen cited up to the IJ level or even K or an L. So this is, probably the one that I would worry about the most. Generally, the others are cited at a lower scope and severity. So we already talked about many of the different types of med errors, but unauthorized medicines, that would be one given without med. And a wrong dose can be as simple as one pill given instead of two, or vice versa. Wrong route. A med was supposed to be given by tube, and the nurse read the order wrong and it was given orally. And I think you're probably mostly at risk when you have agency nurses or nurses that aren't familiar with the residents that they're giving meds to. And sometimes if you look at the orders, they aren't really all that clear. And that's where you need to really, really read them closely to see what the specific instructions are supposed to be. So wrong dosage form, pill, when it was ordered had been changed to a suspension. Wrong medication, it can be as simple as a Senna given when the order was for a Senna S. That is still considered a med error. Wrong time, and then the wrong resident. The resident wasn't identified. Unfortunately, a lot of the new EMR systems have photos, which I think is a really, really great way. More med errors, failure to mix the suspension, shake it well, crushing meds that shouldn't be crushed, failure to give meds with the adequate amount of fluid, not giving meds with food as ordered, and any kind of medication that has a parameter with it. So your blood pressure meds, like, hold of systolic blood pressure is less than 100. You'll come and see. Then sliding scale, making sure that the blood sugar is obtained, and then the med is given after that. So you can't use a blood sugar taken in the morning to do sliding scale at noon, for example. So here's some examples of medication errors. An incomplete dose of Marilax, the little measuring container wasn't full. They got a citation. No apical heart rate with digoxin. Missed doses of insulin were found with no explanation. And it's possible that it was appropriate, but without any explanation, they're going to get a citation. So anytime you hold a medication, you need to have some documentation to support that. We talked about crushing meds, only the ones that you can crush and not long-acting meds. Meds that were signed out, but after some investigation, they had found out that they weren't administered. Not priming an insulin pen before administering a dose. Medications not given before meals as ordered, omeprazoles, and if you have an AC insulin order. Coumadin dosing related to the INR value. Oftentimes, if there's a problem with that, you'll get an IJ, but fortunately, a lot of facilities have gotten away from Coumadin. In this case, the omeprazole was not given for 4 weeks. The order just disappeared. And then when the surveyor, when looking back, found that the order should have been active and the resident had a GI bleed and went to the hospital. So in this case, the facility received a G level. So how do you prevent med errors? So obviously, nurses following the rights of medication administration, clarifying any unclear orders, and as much as possible, communicate any changes of orders to the nurses so that they know to be prepared for that. That would, especially those route changes. And making sure, I don't have this down here, but making sure that who's ever entering your orders into your EMR system know how to do them correctly so that they will read the right way on the MARS. Supervision of text per your regulations, paying attention to your look-alike and sound-alike meds, looking up the ones you aren't familiar with, and then look at your med pass. That morning med pass can be really, really heavy. If you're still using traditional 8 a.m. and 9 a.m., look at perhaps going to liberalized med pass so you have AM and HS. That gives the nurses more time to get through the med pass. Some meds, TID meds, that sort of thing, are going to be at more specified times. And then look at the volumes of meds that are at one time. I went through one time and it's like, this is ridiculous. Nobody can swallow 15 meds at one time. So working with the nurses, we decided, okay, we're going to add some more to the new med time. And that kind of evened things out and not only relieved the nurse of some of the morning med pass burden, but was easier on the resident. So we didn't have to take so many meds at the same time. Insulin second checks and fentanyl patch policy removal, check your policies and make sure when the nurses start out in the morning, they have all the supplies they need. Make sure they have, enough water. They have their applesauce or pudding. You have their spoons. High-risk med dosing. Morphine sulfate, to me, is one of the riskiest medicines that you can give. The orders are very confusing. Need to make sure that the orders are entered consistently. Are you facility-wide using milligrams or are you using mLs? Is it, 0.1? Or is it, 5 milligrams, so that the staff knows how to give them and they are administering the correct dose. And insulin is always a risky med. Don't borrow meds from other residents and avoid interruptions during the med pass. I know this is really, really hard, but it's really, really critical just so that the nurses can stay focused. And I think probably day shift does a pretty good job. There's more people around, but I would ask you to think about supper time. How many extra people do you have in your building to answer that phone? If you have controlled access, who's letting people in your building? Trying to cover things so that, the seniors get their breaks. This is really critical to preventing med errors. And it, requires administrative support to the med nurses to make sure that there's enough people on there so that they can focus their attention on being safe med passers and ongoing nurse education, obviously. Here's some medication administration tips. These came from a nurse consultant friend of mine, and a lot of them are pretty self-explanatory. You could use them for part of an in-service. And here's some more tips. She also gave me some information on eye drops and inhalers and nebulizers, just some quick tips, things that you can look at when you're walking around to make sure that your nurses are following best practice. And I know eye drops are always problem prone when the surveyors are watching. Inhalers and nebulizers, unless the resident's been assessed that they're safe to give their own nebulizer treatment and its care plan, the nurse has to stay with them. And obviously here's insulin and patches and crushed meds. So what should happen if a med error is occurred? The nurse identifies that she's, committed a med error. And depending on the severity of it, obviously the first thing would be to assess the resident and administer any first aid that would be needed, oxygen, CPR, whatever the case may be. The physician needs to be notified, need to follow any orders that you receive from him or her, need to notify the resident, the family. And then whatever appropriate follow-up is. If it's enhanced monitoring of the resident, you need to get some extra labs, need to fill out that incident report, need to let your supervisor know, and then document. And your director of nursing and supervisors will give you will give the nurses some guidance on that. The follow-up is really important. Supervisor, DON, whatever your facility chooses to do, but you need to figure out why it happened. Was the nurse just didn't know? Was she interrupted? And then based upon the results of your root cause analysis, you're going to have to change your policy, change your process, your procedure, provide some education. In some cases, it is truly an error that the nurse did know about, and you'll have to follow whatever your organization's corrective action and remediation practice is. Here's some information for nurses regarding infection control. Infection control is weaved in everything that we do in our organizations, making sure that the nurse has the ability to perform hand hygiene and has most likely just a hand pump of ABHR right on top of the med card. Making sure that gloves are worn, for your injections and eye drops. Some more, just some suggestions about keeping the med cart safe and ready to go. Computer screens, making sure that the med book or the computer screen is turned down so that people going by can't read them. And then resident rights and privacy and dignity are to be respected during med administration. Best practice obviously would not be to give medications in public areas unless the resident consents. And so that's an organizational decision, how and where your med pass is going to happen. The next couple slides here are just a med pass test I made up. Feel free to use it if you choose to. The Institute for Safe Medication Practices has several really good documents that are put out for med safety, and this is a high alert medication document. And they have identified, many medicines such as insulin, any hypoglycemic med, methotrexate, we don't see a lot of, but TPN, parenteral electrolytes, morphine, we talked about, Coumadin, potassium. Those are meds that are higher risk and could cause more problems should there be a med error associated with them. And so it talks about heightened risk of causing significant patient or resident harm when they're used in error. And if you want to look them up, I did put the link, the document at the bottom here. And here's some more of the medicines. Opioids obviously are at high risk as well. And then there's a look-alike, sound-alike list from the same organization. And I was going to try and put some information up here, but it's 9 pages long. So if you are interested, go ahead and click on this link and it will give you that list. And perhaps you already have something like this in your policies and procedures, but it might be something that you would want to include for nurses in service and training. So Constance, we have a poll here. Have you implemented, measures to prevent your nurses from being interrupted during med pass?
We've got 60% saying no and 40% saying yes.
Okay.
It has increased and decreased, 56 and 44%.
Okay.
So
right.
Majority is no.
Okay. Well, I appreciate your honesty there. It is a very challenging thing to do. I understand staffing shortages, as well as I understand budget challenges as well. And perhaps, sometimes it might just be as simple as, changing start times for some people. I know everybody gets really stuck in, what time they want, but maybe the receptionist hours could be altered. I think you just have to look around your organizations. One of the facilities I worked with decided that they wanted a supervisor in-house at all times. And so we had a rotation, and as department heads, we had to take our share of afternoon shifts and extra shifts. We had to work, I think, 8 hours on the weekend from, I think, 9 to 5. So that was just an extra set of hands in a building, as well as, the ability to respond to family issues. So here's another poll. Do you do an annual MedPass competency validation for your nurses? If you aren't, I guess I would suggest that you consider adding that to your annual competencies, since it is such an area that has such a high risk involved to it. So unnecessary medications is F757, and State Operations Manual defines an unnecessary drug as any drug that is excessive in dose or duration, is given without adequate monitoring or indications for use, in the presence of adverse consequences, which indicate the dose should be reduced or discontinued. And there is another resource that I also included down here at the bottom. So some examples are generally related to certain drug classifications. There was a lot of antibiotic examples. So an antibiotic given without signs and symptoms of a urinary tract infection. In this case, the resident fell, went to ER. They said he had a UTI, returned with an order of Bactrim. And we all know this happens fairly frequently. But in this case, there was no assessments in the notes about the urinary tract infection. They made notes about post-fall assessments, but nothing about the possibility of a urinary tract infection. In the next example, the home did not ensure that antibiotics were not administered unnecessarily because they did not have an antibiotic stewardship program. A urine culture was not obtained and the resident received antibiotics for a urinary tract infection. Another example was failure to provide non-pharmaceutical interventions for pain relief prior to administering a PRN dose of a narcotic. And then duplicate therapy, that would be 2 drugs, similar meds for the same condition. And we see this like for antidepressants, antihypertensives. Those are just a couple of examples. And it does happen fairly frequently, and it's okay, but it needs to be addressed in the medical record as to why there needs to be 2 meds. And the residents receiving an antipsychotic med with no AIMS assessment or orthostatic blood pressure because the resident was on that antipsychotic. Care plan did not include monitoring that was needed for a resident on an anticoagulant, and the care plan not in place for monitoring for side effects of an opioid or monitoring for new medications. There was no indication for PRN med. Facility did not follow parameters for medication. In this case, it was for midodrine. So that's for low blood pressure. In this case, the drug was to be held for blood pressure over systolic greater than 110, and they just kept giving the medicine. They didn't monitor the blood pressure at all. And in this case, an antibiotic was given for 52 doses, and the order was only for 40 doses. So it didn't stop when it was supposed to. So how do you prevent these errors? Medication reconciliation is a best practice. So on admission, looking at the meds they've had before, and then the medications are on now, obviously checking for any allergies, looking for those duplicate therapies. And anytime there's a transition of care, the resident goes out to ER and comes back, the resident goes to the hospital and comes back. Best practice for antibiotic therapy would be a 72-hour timeout where you can look at the culture results, check the documentation, see if the resident is responding, making sure that you're following up on the pharmacist's recommendations, which we'll talk about in a minute, looking at your orders, making sure there's stop dates and diagnosis. And most EMR systems won't let you process an order now without all those things in place. Again, the duplicate therapy and looking at your psychoactive medications. 756 talks about drug regimen review and medication regimen review. And the requirement says that the drug regimen review of each resident must be reviewed at least once per month by a licensed pharmacy. That pharmacist needs to also do the admission review of medications. I know some facilities that use point-click care give their pharmacist access to point-click care, and they can do the assessment right in there and put their notes right in there that they reviewed it. As well as the review must report any irregularities. These must go to the physician and the director of nursing, and then these reports must be acted on. The attending physician must document about the irregularity, any actions, And if they choose not to address it, they need to put the rationale for that decision. An additional source of information for pharmacists when they're reviewing medications is the Beers list, which comes from the American Geriatric Society. And again, this is a list of potentially harmful medications to the elders. So the categories would be meds that are potentially inappropriate, was for certain conditions and diseases, meds that can be used with caution, inappropriate drug-to-drug interactions, and meds that need to have their doses adjusted based on renal function. We all know we get the slip from the pharmacy, to look up the creatinine clearance and see if the dose is appropriate. And these black box warnings that come up, they're from the FDA, Federal Drug Administration, for meds that carry the greatest health risks or life-threatening adverse effects. We've pretty much already talked about a lot of these meds: opioids, antipsychotics, the NSAIDs, that would be like your Advils, that are place residents at increased risk of cardiovascular thrombotic events, GI events, bleeds. So your pharmacist comes in or does it electronically. I prefer when they come in so you can talk to them. And they need to review each resident's medications at least every month. When they leave, they should give you a list of recommendations. And that form, the document requires that the physician sign and acknowledge it and address it, as well as the DON. And the meds that they're going to look at your psychoactive meds, look and see if your GDRs are done, if your AIMs have been done. They're going to look at your PRN orders, antibiotic orders. They should look at how you're handling your controlled substances and any other categories you want them to look at. One time, it seemed like we had everybody on omeprazole in my building. So our pharmacist went through and looked for indications and how long residents had been on that. And as a result, we were able to discontinue several orders for those medications. So some examples of 756, month-end review just wasn't done, or it wasn't done in a timely manner. And the failure to follow up on the recommendations that were given from the pharmacist. So you got the forms, but nobody did anything with them. Or in this case, this form was signed by the physician, but the DON did not sign it. Review that was incomplete. It missed the indication for the PRN psychoactive meds, a PRN psychoactive med without an end date. Remember, that should be 14 days, and no review of admission med orders. So how can you prevent citations for drug review? I would make sure that you have a good working relationship with your pharmacy and your pharmacist that comes into your building, so that you know when they're coming and how they're going to give you that information of the reviews. So get a process in place. I actually ended up taking a copy of all the recommendations. After the physicians filled them out, the forms were returned to me. And after a couple of weeks, I reconciled them to the main document to make sure that none got lost or were missed. So get yourself a process, flow sheet document, put somebody in charge of making sure that all these recommendations get addressed. And then, as well as any urgent recommendations, I usually sometimes get called to the facility or faxed to the facility, making sure that there's a way that somebody's going to follow up with them and call the physician immediately. And if it's a severe enough concern, the pharmacy won't release the medications until there is that concern has been acknowledged. And always remember to include your pharmacist as a member of your QAPI team. You need to attend your meetings as much as possible, provide reports for you, and I definitely would include them in any root cause analysis and correction plans that you have for any of these F tags. So we have a poll, Constance. Does your consulting pharmacist provide reports for your QAPI meetings?
We got they're coming in slower. 100% yes. I lied. 11 out of 12, 12 out of 13, 92% yes, and 1 out of 13, 7%.
Okay.
So no.
I would say for whoever answered no, I would push your pharmacist and pharmacy for those recommendations. That's important that you have them. And the right to self-administration of medications is FTAG 554. The reg reads, the resident has the right to self-administer medications if the interdisciplinary team has determined that the practice is clinically appropriate. And the highlighted words there are really important because the meds need to be appropriate for and safe for self-administration. I would most likely say that, a sliding scale insulin wouldn't be appropriate, that the resident has that capacity to swallow meds without problem, open med bottles, or get them out of however you're setting them up, that they have the cognitive ability to know what the meds are for, know their names and side effects and what to watch for, and when to report to the staff. They need to know, if they're going to refuse the meds, they need to let the nurse know, and they need to be able to maintain that they're stored safely and securely. So here's some tags for this, and you will notice that some things were cited here that were also cited in another place. For example, the second example here talks about meds left at the bedside. So it's surveyor specific where they're going to cite some of these issues. Meds left at the bedside, the resident know what they were for, that they were even there, resident sleeping, getting a nebulizer treatment. Medications, inhalers, glucose tablets left at the bedside with no self-assessment done, eye drops at the bedside of a cognitively impaired resident. And the next one down at the bottom here talks about poor interdisciplinary team assessment. The care plan was not updated for the resident who has self-administered his own medications. And the surveyor will go in and talk to these residents about this. And when the resident was interviewed, he didn't know anything about his medications. So how do you avoid these citations? As we mentioned before, don't leave meds at the bedside. The nurses need to observe the medications taking them to make sure that they're being taken. For those residents who want to self-administer, you need to have a thorough assessment of their ability to self-administer. You need to document that the education is provided to the resident. I would have the resident demonstrate that they can take their own medicines, open whatever container they're in. You need to make sure you have a lockbox for them. And this assessment also needs to be repeated quarterly or with a significant change. We had a resident once who all of a sudden took a turn for the worse, who was self-administering her medication. So in that case, we had to take back and administer her medications until she could safely do so again. And in that case, we had to go through the whole assessment process again, keeping the care plan updated all the time. And you still need to check with the resident. Did you take your meds? Make sure and did they have any questions or did they need any more help? These are just some general considerations about medications and pharmacy services to think about, making sure that if you have a lot of meds that are given by tube, that the nurses are following the correct procedure. If you have a lot of IV therapy, that's very much high risk, problem prone. PICs, flushes, your immunizations and TB skin tests, making sure that infection prevention and control practices are followed, documentation and monitoring for adverse and side effects. And areas of concern, as we mentioned, can be cited under different FTAGs. I don't know that there's any specifics. It's whatever. Oftentimes they're kind of lumped with something else. So these are just general steps to prevent medication and pharmacy related citations, your policies and procedures. Make sure you're following best practices. Utilize your pharmacy for resources, audits, use the critical element pathway, do your root cause analysis, put things through QAPI, put your reports through QAPI. So I just have a few final thoughts here. I guess in my opinion, medication administration is a very serious responsibility. And as you can see, there just are so many factors that can affect the med safety of those medications. Pharmacy needs to support nursing. to make sure that the resident care is safe. And from the top down, facility leadership needs to support this process and all these procedures and do whatever you can to make it easier and to make it safer so that and as well as leaves you less for exposure. Several of these tags, like for example, expired medication tabs, kind of in my opinion, that's kind of like low-hanging fruit. If you get a good process in place to make sure your carts and your medrooms in place, maybe you can avoid that tag. So I'd be happy to take any questions that anybody has.
I'm looking. I don't see any right now.
Okay.
I do have a quick question for you.
Sure.
How can non-clinical team members, especially like the nursing home administrator and other ancillary individuals, help support in making sure that things are compliant?
Sure. As with most things in nursing homes, it does take a team, to make sure that things are safe. And sometimes, it's just as simple as, the administrator's walking down the hall and a call light goes on and the nurse is looking all around and there's no CNETs available. And she's like getting ready to lock her meds up and she's got half her meds up and she's trying to remember, what part of the list. She said, well, if the administrator or whoever would go into that room and just check on the resident for her, that way she's not interrupted and she can keep passing her meds. Making sure that the contracts are good with your pharmacy and helping them resolve any issues with the pharmacy. The pharmacies that support our buildings, they administer, they send out thousands of meds every day. So there's bound to be glitches. But if they, run into roadblocks, helping them follow up with those issues, making sure that the meds are there. If they need IT support, so that the nurses have good laptops on the med cards, so that they can read them. Looking at the backup system, if they might need help with that, if you've got a backup med or a new order med that went to the local pharmacy, running out and getting them for them. There's just little things, thoughtful things that can do to support the nurses and what they're doing in the med techs. Does that answer your question?
It does. Thank you very much.
Sure.
And my last question, it goes to about immunizations and ordering things in bulk. How do we stay compliant in those areas, especially when we don't want to run out for residents?
Yeah, I'm a great believer in, always being prepared. The vaccines and those sort of things, it's, you have to make sure that you have the right place to store them. So you need to make sure that you have the appropriate refrigeration for them. And that the refrigerators are monitored for that. And there's many different places to get the vaccines. Some get them from the health departments, some are ordering them from the pharmacies. So making sure that when they are received, that they're given. Sometimes you can group them, but I know it's hard right now with the surveyors coming through. And if, a resident consented to something and it's not given in a reasonable amount of time, you're liable to get a consent for not administering the medication. So I think that's going to be facility specific, but making sure that you can store that and that you have a good way to track what vaccines need to be given to who when will definitely help that out.
Thank you. There's a question in the chat. Do you have tips for accuracy in med reconciliation for liquid narcotics or scheduled drugs?
I'll tell you a quick story. We had a 30 ml vial of morphine. And just for the heck of it, I was wasting a whole new bottle once and I emptied it out into a med cup. And even to start with, it didn't have 30 mLs in it. So, and I remember being so worried, and I talked to our consulting pharmacist and he's going, don't worry about it. It's not a big deal. If you're off like a 0.5 or whatever. As the DON, actually what I ended up doing whenever the nurses would grab me, I just ended up reconciling it, put corrected number. If you're using a syringe, you're going to waste some get stuck in the, the stopper of the bottle. It's just really, really hard. I would just, hopefully, they aren't, don't have a lot of overpours or anything like that are being wasted. And I think you can just be as careful as you can. But yeah, I used to really, really worry about that too. But I think from the pharmacist's opinion, a little bit of that was not probably going to be due to a diversion. If you're, finding patterns, and those are the kind of things you'd watch for: patterns, certain nurses, certain residents, certain shifts. Then your antenna needs to come up and you need to do some more investigations. Some pharmacies will drop your morphine into oral med syringes for you, so you don't have to draw out of the bottles. That works really well. It just depends on what your pharmacy provider will do for you.
I want to remind everybody that if you are in need of an immunization clinic, you can reach out to the immunizations at our immunizations email at immunizations@superiorhealthqa.org, and request a free mobile vaccination clinic. If you're in need with assistance with your EPPs, just doing an EPP plug, please reach out to us. You can reach out there as well. We're trying to call your facilities to talk about EPPs. In addition, we have the Vivint Health modules, the education modules that Mike has just posted in the chat. There's new videos on that that show you all about the modules and the information. So if you're interested in that, it's on our YouTube channel. We have the Frontline Forces modules for everything you can think of, just about, to educate your staff, educate you, educate residents, so that they can educate your residents. You can get that on our Superior Health website, superiorhealthqa.org. Just want to remind you about I'm not going to say that I know what that QSO is all about, because I don't know that I've read it just yet. But before we conclude, I wanted to tell you about our next presentation, which we hope you will join us for the Nursing Home Leadership Roundtable on Wednesday, August 14th at the same time, same place. We're going to continue our series, Turning Deficiencies into Efficiencies, and it will be F0656, Develop and Implement Comprehensive Care Plan. It'll be hosted by Superior Health Quality Alliance. It's a virtual roundtable tailored for nursing home administrators, directors of nursing, but feel free to invite your MDS coordinator, your social worker if they assist with care planning. The more the merry. Ms. Jana Broughton and Kim Heft will be presenting on that topic. They have a nice presentation on resident-centric care planning, and they can guide you through the essential components of comprehensive care plans. So we'll learn how to create individualized, person-centered care plans and bring all your questions that you might have related to care plans, the goals, the preferences, and the strengths. And please don't miss this opportunity to learn more about how to be more resident-centered in your facilities. Before you exit, please click the link to the evaluation in the chat box to provide us with feedback from today's presentation. We thank you all for participating. We look forward to seeing you back here on August 14th. Thanks. Bye.
Thank you. Bye-bye.